Thank you, Rafida. Can you hear me perfectly okay?
Yes, thank you so much, Doctor.
Okay. So good evening, everybody, and thank you for inviting me to host this discussion with you this evening. And I think it is a discussion rather than a lecture, because there's so much in these areas that we can talk about. And I hope that we will make this as interactive as possible for you. Briefly, I'm going to present in the following format. I'll just tell you a little bit about myself. That won't take too long. And then we're going to have the two main sections, which are on smart devices and on risk calculators or risk calculations. And then we will have plenty of time at the end for questions and answers. Although if you do feel there is anything particularly pertinent that you wish to stop me for during the presentation, that's absolutely fine. We can try and address things as we go along. So just to let you know, like yourself, I'm a family doctor. Looking at the three slides here, on the left-hand side was a map of Ireland. I work in the town of Drogheda, which is difficult to pronounce, and it's about 50 kilometers north of Dublin. On the right-hand side was a picture of the clinic in which I work, and down below there is a picture of some of us working in the clinic. That is me in the green. I also work for what is known as the GPIT group of the Irish College of General Practitioners or Family Practice, and this is made up of representatives from the family doctors representative body from our college, from the Department of Health in Ireland, and from the Health Service Executive, which really runs these services on behalf of the Department of Health. And the aim of our group is to promote all things e-health, in particular communication and interoperability between family doctors and anything which is run by the National Health Service. And I put a link to our page there if anybody wants to have a look at it later on. I suppose our initial aim, going back to the 1990s, maybe 25, 30 years ago, was computerization of general practice or family practice in Ireland. But since 15 years, we have been mainly two functions. One is an education section for matters IT for family doctors, and the second is a projects group which works to develop this integrated approach to primary care of all forms and communication with the secondary care system. If I look at the last 10 years in particular, I suppose this is just a flavor of what we have been doing. We have tried to computerize the remaining family practices that are not computerized. We try and supply support to them all and to provide education for those difficult bits. With computerization, there is a need to look at data security, good internet practices, data privacy, and we're also involved in setting of standards. I don't know how it works for you in Saudi, but we have 4 softwares which are used in family medicine, and we provide certification standards so they do all the tasks that family doctors require. We liaise with national projects, and for example, all laboratory and radiology results are integrated into our software. We can refer electronically, and we have secure email called Health Mail, which allows us to communicate securely with the hospital system and other sections in healthcare. During the pandemic, we had particular issues like everybody else, and it allowed us to move forward with paperless transfers of prescriptions, with transferring of certification to our Department of Social Welfare. Specifically for our family doctor colleagues, we provided advice on remote consultations and remote working if the need arose. We also had a major cyber attack in the middle of this year. So therefore, we've had to respond to that by providing an IT security for family doctors. And of course, we have been involved a lot in monitoring COVID, whether that be in arranging tests or arranging vaccinations, and trying to ensure that the appropriate information has been returned to our Department of Health in an electronic format and as quickly as possible. I also do a little bit of work with an umbrella group called eHealth Ireland, which looks at all matters digital and health. There is a process in place looking at the introduction of SNOMED CT terminology, which will eventually supplement and probably replace ICD-10, the International Classification of Disease. We're looking at extending electronic health records to our colleagues who work in primary care but who are not presently computerized. We'd like to see, with the European Union, the ability to transfer records across border, starting initially with patient summaries and prescribing information. And again, during COVID, I have worked with a virtual health steering group looking at video-enabled care and remote monitoring for patients. And I suppose that becomes particularly relevant to what we're going to discuss for the rest of this evening. So we're going to start in a minute to look at smart devices and ask the question, what do we need to know? But I'm initially just going to launch a quick poll for you. I'd be grateful if you could respond. And this is asking you, have you used any of these devices as part of a smart device system? So whether that would be blood pressure monitors, pulse oximeters, thermometer, glucometers, any of these, have you been using them remotely? Have you been using as what you consider to be a smart device? And we'll touch on what is a smart device in a minute, but I'd be interested just in your impressions of this. So we'll give this another 20 or 30 seconds just to run through this poll. Thank you very much for putting your answers in. I think we're about halfway there. We'll just give this another maybe 15, 20 seconds, and then we'll close the poll. Okay, so we'll end the poll here. What I'm seeing is that many of you have used some of these devices, probably equal amounts of blood pressure monitors, pulse oximeters, glucometers, some using thermometers, some not using any, and one or two people not, very reasonably not being sure what we mean by a smart device. So I'll just share these results with you now. And all of this is anonymous, so that's fine. So they're the results we're seeing. About half of all of you have used BP monitors, pulse oximeters, glucometers in a smart device way. So, so we're going to try and answer this question then of what do we mean by, sorry, apologies, smart devices, and what do we need to know? So we're going to start off. The first question is, what is required to be a good smart device? What is a smart device? And we look at some case studies of smart devices that I have used or am aware of their uses. This is one definition of what is a smart healthcare device. And it is only one definition, but it is likely that for a smart device, it needs at least some of these properties. So we're talking about a sensor, which measures a physical property, be that temperature or blood pressure. An aggregator, which is a little piece of software which transforms the data into information, which can then be transferred through some communication channel, be that Bluetooth, for example, into a further piece of hardware which will process and make sense of that data which is coming in, and possibly be augmented by some kind of decision trigger, which may give feedback to the device or feedback to a portal which is being monitored by clinicians. But I'm going to ask a more fundamental question from my own mind, which is, what do family doctors and their patients really need? There is a huge amount of potential smart devices out there, and we don't necessarily need them all. So let's try and answer that question first. And for me, and you may agree or you may disagree, but I think smart devices are most useful for us where there is frequent variability in a parameter. So as we all know, to measure somebody's blood pressure in an office or a clinic for 10 minutes or 15 minutes may be representative or may not be representative if you do not see that patient for another 6 months. So because blood pressure, as we know, varies quite considerably, heart rhythm likewise, blood glucose readings, oxygen levels, and again, so the ability to have a patient measuring this via a smart device can be very, very useful if we want a true representation of what is going on and not just look at a moment in time. Remote monitoring is particularly useful in any set of circumstances where there is reduced access to medical services. For example, if a patient is geographically remote from the clinic, if it is difficult for them to access your services, and many of us have faced this during COVID, where we have not been encouraging patients to attend clinics in the way that we would normally do. And to use remote monitoring with smart devices can be very, very helpful. It can contribute not just to managing patient care well, but it can also contribute to patient education and to partnership with the patient. Now, I'm going to get a little bit technical for a minute. This really isn't too technical, but it's just questions that one must ask when we are thinking about smart devices. And these are all fairly obvious questions you will see as we kind of run through them. So a smart device must be accurate. It must be reliable. Ideally, it should be kind of accredited as a recognized standard. And even having ticked those first three boxes, it should be maintained because, as we know, certain devices will not be reliable as time goes by. Ideally, there are different parts of the world which have different units, so it should conform to local standards. And then if we are storing and transmitting data, we need good governance of it. It must be secure. Ideally, it should not be locked into a vendor system and be interoperable with other pieces of IT which we use. And then once it is somewhere, can we now find it? Can we search it? Can we get into it very easily? And I suppose when we look at a lot of information which can be stored, we go back and ask that question, is it important? If you have patients who like their Fitbits or Apple Watches and record their 10, 15, 20,000 steps every day, does that really matter? Do you want that information shared with you? So the relevance is important. So I'm going to share with you some case studies, and very specifically 3 case studies, which are from an Irish setting, but they are examples of things which are used internationally, and you may indeed have some similar products in use in your own country. The first one I'm talking about is a thing called Patient Empower. And everything on this slide is in quotes because this comes from Patient Empower's description of themselves. So they're a digital healthcare company providing virtual care solutions for primarily aimed at people living with chronic illnesses. We talked about education before. So their second claim is that it empowers chronic education patients to manage their own health from the comfort of their own home. But it also importantly allows healthcare professionals such as family doctors to manage these chronic conditions using virtual care pathways. So let's see what that means. We have a couple of pieces of equipment here which would be fairly recognizable by you all: a spirometer, a pulse oximeter, a blood pressure monitor, and a weighing scale. And on the right-hand side of the screen, you can see a mobile telephone with an app which contains a certain amount of information which has been received via some of these devices. At the other end, there is messaging for both doctor and patient. On the left-hand side, there is a screen which tells a doctor or a nurse or some healthcare professional or somebody who is monitoring the information what has happened about a certain patient. On the right-hand side, there is an example of a text message, such as a simple medication reminder, or this could be a reminder to take a particular measurement. When we go further into the clinician screen via a web portal. If the patient has done spirometry today, you can get readings of that spirometry on the clinician's screen. And again, this is all very customizable. On the top here, we have examples of the patient app screen with particular questions which were set up for the use during the time of COVID. So is breathing more difficult than normal? How breathless are you? There are some measurements from your pulse oximeter. Also a question, do you have diarrhea? And again, how bad the diarrhea is. At the bottom half, we have now a clinician dashboard, which allows the clinician, the doctor, to dip into various parts of the information, such as on the right-hand half at the bottom, there is particular patient information looking at their oxygen saturation and how that has varied over a period of time. So this is an example. There are probably many, many similar platforms. You may have been using them. Not all smart features are there, but some can still be extremely useful. And I'm just mentioning here an app from the United Kingdom called Florence, and that is its website, which encourages people via text reminders to do their own measurements. The patient enters the data themselves, so they're not necessarily using a smart device, but the algorithm is smart, and the algorithm connects to a clinician portal. So without necessarily having a device which is Bluetooth connected, we can still get the appropriate information. So that's what I mean by having varying degrees of how smart things are. Now, case study number 2 is the thing called Dexcom G6, which is a flash glucometer. There is a Saudi site, so I presume this may be familiar to some of you. And this again is allowing patients, particularly with insulin-dependent diabetes, to monitor their glucose at home, and at the same time to have some access for clinicians to monitor that as well. So these are the components. On the left-hand side, the thing with the orange button is the applicator, through which a sensor is pressed onto the body of the patient. And the sensor has a small little filament which pierces the skin and measures glucose levels in the patient's interstitial fluid. Number 2, the little thing at the bottom is the transmitter, which is attached to the sensor. And then that transmits either to a particular device for Dexcom, or more commonly used to a smart device such as a mobile telephone or a smart watch. There are 3 options for placing the sensor and the transmitter. The 2 most commonly are the back of the upper arm or on the abdomen. For younger patients, there is the option to put it on the upper outer side of the buttocks. And this is what the patient sees on their app or on their mobile telephone. You have your current glucose reading, which may be going up as shown by an up arrow or down by a down arrow. There are different colors to the reading, which shows you whether you're in range or out of range. And there is also a graphical representation, which can be set for a period of 3 hours or 6 hours or 12 hours or 24 hours as you care. And again, the right-hand side shows how you, as a patient, can customize that to your own individual needs. There is a partner app called Dexcom Clarity, which allows greater analytics, and this can be shared between, again, doctor and patient. Gives a little bit more of an overview of the glucose readings for longer periods of time, including things like time in range. And this can be very useful for a clinician to access when the patient next visits. You don't have to be monitoring this all the time, but when the patient visits your clinic, you can perhaps spend some time running through how their glucose has been over the past period of time. There is a similar product called Abbott Freestyle Libre, or Freestyle Libre, which is made by Abbott. The difference with Freestyle Libre is that you have to pick up your device to monitor and just run it across your upper arm or your abdomen to take a reading, whereas with the Dexcom device, what is happening is there is continuous monitoring to your phone as long as your phone is within 6 meters of your person. And of course, this can be taken to a logical conclusion using things like insulin pump, where the reading affects how much insulin is being delivered in your body, and it's a complete closed loop of the system, which certainly can be overridden to give yourself some more insulin, but the insulin is adjusted from an algorithm which comes from the glucose readings. My third case study is slightly different. This is a group in Ireland called Halocare, which describes itself as empowering older people to live quality, more connected lives in their own home for longer. And if we look at what is part of this device or this system, we have on the left-hand side the usually elderly resident or vulnerable resident, and in their house they have a variety of sensors which can sense whether they're moving from room to room, can be set up to detect water spilling or going onto floors or onto work surfaces, can be smoke detectors, there can be fall sensors, there can be door sensors to detect if doors are opening and closing, and there is a voice alarm. And this is trained to recognize patterns of movement. Now, there is no closed circuit television, there are no cameras, but it is trained to recognize, particularly for elderly people, have they left the front door open, have they left the bath running, have they had a fall, this kind of thing. It uses a smart algorithm and analytics and is monitored by a call center that you can see on the right-hand side, which can then alert family members, can check in with the resident or the elderly person themselves, often usually makes a call every day to check that everything is okay. And it's a security which allows people to know that there is a certain amount of care for them in their own setting, where maybe younger family members are out at work or living remotely from them. So to summarize smart devices, this is a rapidly changing topic, as we discussed at the start. We will undoubtedly see more and better devices and better systems developing over the next 5, 10, 20 years. We do have to consider data management, because there is the potential here for being data overloaded, and we need to try and figure out what is relevant, what isn't. So just to conclude this particular section, again, we're just going to run through the principles which will help assess what is a good smart device. So I've shown you this slide already, but I'm just going to finish this section by showing you again. So it has to be accurate. So bad information is worse than no information. It needs to be reliable, so it can be trusted to work when you really need it. Ideally, this should be a tested and accredited solution rather than some maybe startup that hasn't necessarily done the hard work. It needs to be maintained. It needs to be updated as things change. And is it a device which is useful in your own local settings? We need to know what happens to data which is collected by smart devices. Is there good governance? Is there good security? And ideally, it should not be locked into a vendor system, which makes it difficult to extract. And we want to know, can you find the data? Is there a nice portal which allows you to find the data when you want to see it, to search it if possible? And again, we go back to that fundamental question of, is the information really important to you in your work as a family doctor? Now, we're going to move on shortly to the section on risk calculators. What I'm going to do before that, however, is I'm going to launch another poll. And this is a very specific question about cardiovascular risk calculators. And again, this is all anonymous, but I'd just be curious to know which of the following cardiovascular risk calculators do you use? And I've named a couple here: QRisk, the American College of Cardiology, AHA as well, the American Heart Association, the same one. HeartScore is the European Association version, and Framing is the more long-standing American one. I've given you an option of other, if there is another one which I'm not aware of that you're using, and also an option with none of these if that is relevant. Could I ask you, Rafida, are there any kind of questions which need to be answered at this stage while this poll is running? Okay, if I hear no questions, then we will just let this poll run for another 10 or 15 minutes. Sorry, 10 or 15 seconds. And I'm going to end the poll now. I'm going to share the results with you, which I hope you can see, which shows that the thing which you seem to be using most is the American College of Cardiology Cardiovascular Risk Calculator, and I will I'll talk about this in a couple of minutes. Okay, so we're going to talk about risk calculations and risk calculators and look at some of the tools and apps that I'm aware of usage, and you may indeed have others, because as I say, there is no monopoly of wisdom on this particular topic. But again, let's start at the very basics. So there are multiple calculators which are available out there. And I suppose they're going to be most useful for common conditions, chronic conditions, serious conditions. And we've got to remember how these calculators arise in the first place. So they're often based on analyses of populations. So therefore, they may be they may need to be adjusted by geographical regions, and we're going to look at some examples of this. This is a slide from a website called patient.info, which is a United Kingdom-based patient information. I must say I find it very useful for information on all sorts of sort of patient topics, but it does have a list of some of the more commonly used calculators in this particular kind of part of the world, and we will be looking at some of these in a little bit more detail. These are apps to consider when one wants to try and pool all your calculators and calculations in one spot. I suppose the most recognized, most popular would be MD Calc, which we'll discuss in more details, which has hundreds of calculators to use. For any of you who use UpToDate, which, as you know, is a kind of medical resource online, again, calculators are part of what they offer. And the right-hand slide there is another offering for a mobile phone with a family medicine edition, and that's called Calculate. So I'm going to start with a little bit more discussion of MD Calc. As I say, it is literally hundreds of calculators available to you, most of which you will never use. It is customizable, and if we look at the screenshot there, you can see just below MD Calc on the search button, the writing is very small, I'm afraid, but it says there are popular ones, there are ones you've recently used. You can set your own favorites, you can search by your own specialty, and you can search guidelines as well. Ideally, I would make the comment that it is better if commonly used calculators are part of any clinical software you are using on a regular basis. And if this can be arranged rather than having to visit external sites every time you need to use a calculator, that is really helpful. The main and obvious reason for this is if you have a calculator which is based on inputting certain readings like blood pressure or weight or cholesterol levels, If that happens automatically, that is a lot easier than you having to sort of re-enter that data yourself. So I issued a poll about cardiovascular risk calculators because I suppose cardiovascular disease is an important topic in every part of the world, and is something which a lot of work has been done on risk calculation. The ones I showed you were, or ones I mentioned in the poll, were HeartScore, which is the European Society, QRisk, which is a United Kingdom based one out of the University of Nottingham, Framingham, which was the original American one looking at US veterans, and which has probably largely been superseded by the American Heart Association, ACC, American College of Cardiology calculator, and we'll look at these in a little bit more detail. I'm also going to show you a thing called Absolute CVD Risk Calculator in a few minutes, and you'll see why when I do that. Firstly, just to remind ourselves why geography is important. This is the WHO cardiovascular risk lab-based charts for Europe, for Western Europe, and you may recognize these, and this separates people out by age, by sex, by whether male or female, whether they're smokers or non-smokers, what their systolic blood pressure is, and what their cholesterol levels are. They're the important things. And you get that visual chart which says the dark red is very bad, which you would kind of expect in older men who smoke with high blood pressure and high cholesterol, down to the bottom left-hand corner, which is in younger non-smoking kind of females with low cholesterol. You have a very low risk. However, I just want you to get a quick snapshot of that and look at it and just get the idea of how much is red and how much is green. And then I'm going to just move to North Africa and the Middle East, where you can see that there is a lot more red and a lot less green. I'll just flick between the two for you again here. And I suppose this simply makes the point that geography is important. Therefore, the WHO, in providing these scores for us, take into account people's geography. However, when we go back to using the online calculators, it may not necessarily be possible to set it for your own region. Therefore, you have to make allowances for that. I found this study in the literature. Some or all of you may be aware of it, which was a comparison of 4 cardiovascular risk calculators in Saudi patients. And the conclusion of this particular study was that the QRisk, which is the UK one, is easy to implement and can be applicable in a population-based study, but the ACC-AHA is superior in predicting individuals with a higher risk of cardiovascular disease. So we'll start with this. The American College of Cardiology, American Heart Association, their ASCVD Risk Estimator Plus, which is the latest version, and this screen may be familiar, again, looking at age, race, sex, blood pressure, cholesterol, and adding in a few extra questions relating to diabetes, whether somebody is on hypertension treatment or on a statin or on aspirin therapy. This, in comparison, is QRisk, which is the kind of British version. And hopefully you can read those questions on the left-hand side. But what we're seeing now in QRisk 3 is further questions have been asked because they have been seen to be relevant to the calculation. So if we look at the middle section, which is clinical information, as well as having smoking, diabetes status, we're looking at whether somebody's had cardiovascular disease in the first degree relative, whether they have chronic kidney disease, atrial fibrillation, whether they have migraines, rheumatoid arthritis, or SLE, whether they have severe mental illness or being on antipsychotic medication, or indeed on steroids or suffering from erectile dysfunction, as well as all the usual questions. And these have been modified on the basis of data which is continually being collected by this particular group who run QRisk. I said I would show this screen to you, which is the absolute CVD risk calculator, and I've given the link to the site there. I'm just going to take you through this for a couple of minutes. On the top of the screen, you will see Framingham, Q-risk, again, the ASCVD, and Predict, which is the New Zealand sort of version of the same thing. If we then move down, on the left-hand side, there are 3 columns. The first column allows you to enter data of the usual kind of information, but it will be specific to which calculator you're using. In this case, I've highlighted the ASCVD at the top, so we're using the American questions. On the right-hand side, you see risk represented visually in terms of the smiley faces. So for this particular patient with their figures, they have a 10-year risk, 80% of nothing happening, and 19.3% with an event. And the middle section I'll come to you shortly. So I'm going to take the same patient, and we're now going to look at possible interventions. And in this particular case, if we look at the middle column first, I've taken the same data, but I've asked what would happen if we used a low to moderate intensity statin. And immediately below where I've clicked low to moderate intensity statin, we have a little new box appear which says harm of intervention. Initially, muscle aches and stiffness. NNH is the number needed to harm, which would be 10 to 20. Increased liver functions, number needed to harm is 250, so very rare. Severe muscle or kidney disease, number needed to harm 10,000. So that you 10,000 patients to treat to harm 1. On the right-hand side, we have the benefit of the intervention, which is of our 20% who were at risk, we now see that 5% of that 20, so 5 of the 20 now have a smiley green face. So these are the 4.8% who will benefit from that intervention. Overall, 4.8% is not great, but it is 20% or 25% of the 20% who were at higher risk in the first place. And we also see in the pale pink and the darker kind of red, those who would be at risk because of baseline events such as age and sex, and those whose additional events are caused by risk factors, and this would be their cholesterol, their smoking habit, or their blood pressure. Now, we see the 5 smiley faces there introduced by the low to moderate intensity statins. I'm taking exactly the same data here, but what I'm doing is I'm offering the intervention of physical activity. And what we see here is that physical activity produces much the same benefit as low to moderate intensity statins. However, the harm of intervention is an awful lot less, other than activity-related injury. And there are certainly some additional benefits like effect on mood, effect on sleep quality, and maybe benefits of arthritis. So I think this particular example shows that this is quite a nice one to share with the patient. It can be a motivational tool. It can tell them what the benefits of statins are, or indeed all those other options that we have in the central column. But it can also show what the benefits are of sort of lifestyle things such as smoking less, different types of diets, and physical activity. So if you really feel that you'd like your patients to exercise more and eat a better diet rather than taking more tablets, this is one way, but perhaps you could persuade them. Now, again, we're talking about populations here. So again, this is a busy slide, but really the bottom is divided into 2. And what I've done is I've compared Q risk and the ASCVD, the American college ones. And really what I'm getting you to show here is with exactly the same set of data, if we look at the risk figures on the 2 examples, with the same data, we're getting different analyses of risk using the American model and the British model. And again, it just illustrates the importance of geography. You could argue that the absolute numbers are not always important. What is important is to demonstrate using this particular tool that there is a benefit from particular interventions, and maybe that's what the patient needs to know. So I'm going to quickly run through some other calculators of interest: CHA2DS2-VASc, HAS-BLED, Frax, and the WELL score. CHA2DS2-VASc, as you know, is for calculating the risk of stroke in people with non-rheumatic atrial fibrillation. And again, you get scores for age, sex, heart failure history, hypertension history, previous stroke history, vascular disease history, and diabetes history. And this is important because depending on local guidelines, it may decide whether you should be on aspirin or whether you should be on an anticoagulant of some form. However, there's often a good idea to use the sort of HAS-BLED calculator, which assesses bleeding risk alongside the need for anticoagulation. So again, combining the CHA2DS2-VASc with HAS-BLED can allow you to optimize the right kind of treatment for your patient. And again, I suppose it just highlights the fact that calculators are indeed just calculators. They are not gospel, and they are never a substitute for your best clinical acumen on dealing with a particular patient and topic. I'm now going just to quickly show you the Frax tool, which, as you know, is a measurement tool for osteoporosis. And again, highlight the fact that Frax works internationally and has tailored its calculator to the Saudi population. Indeed, you can get the calculation for virtually any country in the world. So I will not say any more about that. If you look at the link to Frax on the bottom of the screen, you can then find the link to your own local population. WELL score is a score to assess risk of deep vein thrombosis. And again, you can see the questions which should be asked about whether somebody's been bedridden, looking at their whether they have active cancer, certain measurements that one takes. But again, you've got to remember this only gives you a score and only gives you a low or high risk of whether somebody has a DVT or not, and therefore gives you some kind of advice as to whether this person now needs further assessment in hospital or using some kind of imaging technique. I'm going to show you this screen, which again is very, very busy, but is basically to say that the same people who do Q-risk have also turned their hands to using calculators for other diseases, such as cancer, diabetes, and kidney disease. I think this is a very British thing. It's not something I would use very much myself, but I put it there for interest to say that, again, there are plenty of calculators out there if you are looking for them. So if we may complete this section by saying, well, you know, let's just ask the question again, what makes a good risk calculator? It should be reliable. So the information that the calculation that you're doing should be meaningful to your patient. It should be appropriate for your particular location and geography. Ideally, I think it should be part of whatever software you use in your clinic on a daily basis. And of course, it is a risk calculator. It is no more than that. And it is not a substitute for a clinical assessment. So that is now the end of what I'm going to present. I'm going to launch one more poll for you. And then when we have got in the answers to that particular poll, I'll be very happy to answer any questions on any of the things that I have discussed, and indeed anything else that you would like to ask me relating to these topics. I hope that's been a useful overview. I don't particularly claim to have a monopoly of wisdom, and there may be things which you are using which are better than the smart devices that I have mentioned or indeed that I'm using. But I'd be very interested to discuss these things with you, and we'll do that just after we launch this poll now. And I suppose this is really to ask you at the end of all this, do you think that sort of, how do you feel about smart devices? Do you think, not for me yet, like to use them a little bit? I can see them becoming a significant part of my practice as time goes by. Or do you feel that really smart devices are the future of medicine? Dare I say, at your expense? I mean, could the devices become so smart that we don't need as many doctors in the future? So have a think about that when you're answering the questions. So we'll give this another, just another 20, 30 seconds. While I'm doing that, I might sort of also pass back to my co-host to ask, are there any questions that have come in so far? Is there anything that anybody would like to ask me? I will try and answer that as best I can in a couple of minutes. I'm going to end the poll in 10 seconds now and share the results with you. Results are coming in very shortly. Okay, I'm just going to end it now. 5, 4, 3, 2, 1. Sharing the results, and I think it was what answer suits you best. And I think what we're seeing, and what I would be inclined to agree with, is that smart devices will become a significant part of all our practices in the sort of 10, 20 years ahead. But we hope there will still be a need for doctors. So, okay, can I answer any questions?
Good evening, sir.
Good evening.
My name is Dr. Timmy. I'm calling from Al Qasim region. Practice there as a family physician.
Good evening, sir.
I just have a few observations. They're not questions per se. Being human beings, and as is common of devices, including natural human living, availability of power, presence or availability of data information on network, as well as fluctuations, and in some rural conditions, these could constitute a great part of hindrance to achieving the desired goals that you presented for us about the use of those smart devices. How would we overcome, if it is possible, such hindrances? Thank you.
Sorry, your line was just breaking up a little bit there. Just what was that key question?
Okay, sorry. Like I was saying, as is common of... Hello, are you hearing me now?
Yeah, I'm hearing you. It just breaks up a little bit occasionally. I'm sorry.
Yes, this is part of the problem I was trying to put forward.
Doctor, I'm sorry to interrupt. I think if you can keep your voice, your mouth away from the speaker a little bit, from the microphone, so he can hear you. I think this is the problem. Or if you want to write it down. Thank you, doctor.
Thank you, Madam. Is it better now?
Yes, that's a bit better. Thank you.
Okay, I brought it closer with the view to making you hear me clearer first time. So what I was saying in essence is, as is common of human beings and nature with scientific devices, power supply, including data availability and fluctuation, just like the one I just had, and you're not hearing me clearly, could become hindrances to a complete or proper use of these scientific devices to aid both diagnosis and management of patients. So for such purposes like power, data fluctuations, or non-availability, how would we have a way of overcoming such hindrances based on the usefulness of your presentation about the use of such devices? Thank you.
I mean, I suppose it's difficult, isn't it? I think every device must be tailored to an individual sets of circumstances. So people working in remote rural areas have very, very different needs to people working in urban clinics. But the key thing which is useful for smart devices is, I think it's the concept of remote monitoring. The fact that patients can be monitored at some distance from where you are. And if you can, and again, cost, of course, is very relevant as well. So we looked at all those parts that need to work. So I mentioned the example of Florence from Britain, from the United Kingdom, where patients could use a more simple device, which isn't necessarily that smart in as much as it's not connected by Bluetooth, but they could enter data, they could send it, they could record data themselves, and they could send that back periodically to you. And that's, you know, it's a low-key smart solution. Or, you know, with something as basic as a mobile telephone, you add the algorithm to the mobile telephone, and that says to you, and this is what Florence does, it is, I enter my blood pressure for today into the Florence app, and it says, your blood pressure is fine, please check it again in 1 week. Or it says, your blood pressure is too high, check it again in half an hour. Or it says, your blood pressure is very high, we better send a message to your doctor. So you know, you can start with relatively unsophisticated equipment, and you can kind of build it up to whatever circumstances allow you to work with. Does that answer your question?
Yes, sir. The reason for my asking is because as family physicians, we are primary care specialists, and the purview of our practice should even be more in the rural area. That was the reason for my question. Thank you.
Thank you. There's a question which I received on the chat, which is, if we had different results of same patient with different calculator, which one should I rely on to provide best treatment for this patient? And I suppose the answer to that really is trying to understand and trying to know in advance which calculator is most applicable to your local population. So I showed the World Health Organization charts, which are very much customized to a population, but are not necessarily part of a smart app and algorithm which is available to you. You could build in factors. So you could say, well, roughly, I think the numbers are maybe 50% higher for a Saudi patient compared to a Western European patient or an American patient if you're using the ACC. I think that's something which really needs to be discussed at a local level. So you need to compare your local your local calculations with these calculators which are provided for populations which are not based in the Middle East. I might also refer you to that paper that I quoted if you have the slides available to you at the end, which was very much trying to answer that question for the Saudi population. Are there any other questions that are coming in? somebody asked earlier on about what smart devices do I actually use myself. So the glucometers we certainly use the Dexcom or the Freestyle Libre. I find they're extremely useful for patients who have insulin dependent diabetes, again, because you get such kind of variability. In terms of smart blood pressure monitors, I have, I suppose I've used hybrid systems. So I'm very happy for patients to get a blood pressure monitor at home and link it to their own mobile phone and send me their results if they wish to do that. I always say to patients who are being treated and being monitored for hypertension, which I say this, that they, when they present to me in the clinic, it is not to pass a test, it is that they and I should both be happy that their blood pressure is well controlled. And I think that's a really important statement to make, because I think patients do get nervous attending the doctor, and you can see white coat hypertension, somebody sitting in front of you. And so if somebody has access occasionally to a 24-hour monitor or any form of home monitor which is reliable and will give periodic readings between clinic visits, I'm really happy to use that data. I think that gives me more accurate information as to how well their blood pressure is controlled than my seeing them once every so many months and trying to make a judgment on 1 or 2 readings in 15 minutes. I've been asked, do insurance companies cover smart devices for all patients? I think certainly in Ireland they don't. Again, that may have some geographical variation. I think a lot of devices are going down in price, but affordability for your own patient population is obviously important, and that may be something that you discuss with them. And I mean, I would sometimes argue, well, discuss with patients, is it better value for them to spend some money on buying a device which is a smart device, and which may mean less trips to see the doctor. Now, in Ireland, certain patients would be insured by the state for things like glucometers, like Dexcom and Freestyle Libre, but it's a very narrow section of population and certainly wouldn't apply to all diabetics. Has anybody else any questions you would like to ask? I'm happy to stay here some while longer if that would be useful. Rafida, are you seeing anything on the dashboard? But I'm not.
No, not yet actually.
Okay.
I think we don't have any more questions. Doctor, please, if you have any question, just let us know. If you don't, then we would like to really thank you, Dr. Connor, for presenting such a topic. And the presentation of Dr. Connor, inshallah, it's going to be sent to all of you, to your emails, the emails that you have registered through. I think we don't have any more questions. Yes. So thank you so much, everyone, for attending. Thank you so much, Dr. Connor, for giving such a topic. We really appreciate your efforts. And yeah, have a great rest of the day then.
You're very welcome. Thank you for your attention and your attendance. I hope that was some help to everybody. And if there are any follow-up questions, I'd be very happy to take them by email and try to get back to you.
It is. Thank you, Doctor. We really appreciate it. Thank you, everyone. Have a great rest of the day.